Thank you for the kind introduction. Good evening, everyone. I'm Wilson, one of the unaccredited general surgical registrars at the Alfred, and I'm grateful to be given the opportunity to present here. My study is titled Non-Operative Management for Small Bowel Obstruction in the Virgin Abdomen, a Systematic Review. Before I begin, I also wish to state that I'm the primary researcher for the study, and I declare no conflicts of interest. Small bowel obstruction is a common general surgical presentation which accounts for at least 12% of surgical admissions and more than 300,000 operations annually. Traditional surgical teaching decrees that one should never let the sun rise or set in a small bowel obstruction. Over time, there has been a gradual shift in its management from definite operative intervention to a more conservative approach. Conventionally, explorative surgery has been advocated in patients with a virgin abdomen due to concerns regarding malignancy or an obstructing lesion. However, there is increasing evidence showing that a subset of these patients can be treated conservatively. Hence, we perform a systematic review to assess if non-operative management can be a safe and feasible option in patients with small bowel obstruction and a virgin abdomen. Our secondary aims were to compare associated mortality and morbidity rates and identify its etiologies in this group of patients. Our systematic review was performed in accordance to the PRISMA guidelines as shown in this figure. We identified relevant studies between 1995 and 2020 using the keywords virgin abdomen and or small bowel obstruction. From our initial search, there were 44 papers and it was cut down to 6 papers. The 6 included studies are shown in this table. All the studies were retrospective observational case series, including one which utilized a prospectively collected database. All studies scored 6 or more on the Newcastle-Ottawa scale and therefore were deemed good quality studies. The modality of non-operative management were varied, with the most consistent approach keeping the patient new by mouth with gradual diet upgrade. Nasogastric tube insertion for the purpose of decompression was used in 4 studies, and 2 studies utilized the gastrograph and oral contrast agent approach. Amongst a total of 416 patients, 205 or 49.3% had non-operative management, and 211 or 51.7% underwent explorative surgery. In the non-operative group, 196 patients or 95.6% were successfully treated, and the remaining 9 patients failed conservative management and required surgery. In the explorative surgery group, 187 patients or 88.6% were successfully treated. The remaining 24 patients had a negative explorative surgery, meaning that nothing unusual was found and therefore nothing was done intraoperatively. Within the non-operative management group, 3 out of 96 patients, or 3%, suffered from aspiration pneumonia, and in the explorative surgery group, 13 out of 50 patients, or 26%, suffered from both aspiration pneumonia and superficial surgical site infections. In regards to mortality rates, both groups had 0 fatalities reported. The commonest etiologies of small bowel obstruction in the virgin abdomen were adhesions at 63%, malignancy at 11%, foreign body of the zoa at 5%, or internal hernia and volvulus both at 4% each. Other causes included inflammation, gallstone ileus, and Meckel's diverticulum. As mentioned in the previous slide, the high success rate of non-operative management is possible because the predominant etiology of small bowel obstruction in this group is adhesions, accounting for 63% in our study. Adhesions may be congenital or may have developed as a result of previous intra-abdominal infections. Furthermore, with the wide availability of CT scans nowadays, such patients can be stratified appropriately by detecting other non-adhesional intra-abdominal pathologies. Not surprisingly, we found that the CT scan is highly utilized, ranging from 93.5% to 100% across the studies. From our findings, we recommend non-operative management in a select group of patients, with exclusion based on criteria presented here in this table. It is imperative to recognize that operative management is still necessary in patients with hemodynamic instability, clinical features of peritonism, incarcerated hernia, closed loop obstruction, or obstructing tumor. These cases have a high index of suspicion of bowel strangulation, which may lead to ischemia, necrosis, or perforation. Emergency operative intervention should not be delayed in these patients as the consequence will be catastrophic. There are a few limitations identified in this study. Firstly, there was significant outcome measure heterogeneity amongst these studies, which made data summation by a meta-analysis not possible. Secondly, the small number of papers identified in this review, in which all were non-randomized and retrospective in design with their inherent bias. In conclusion, non-operative management for small bowel obstruction is a safe and feasible option in patients with a virgin abdomen. Patients should be carefully selected for this management protocol. Adhesions are the most common cause of small bowel obstruction in this group of patients. Looking ahead, further large-scale prospective clinical studies with standardized management modality, homogeneous clinical resolution indicators, and long-term follow-up data are warranted to allow for quantitative analysis to reinforce this evidence. Here are my references. And thank you.
Thank you, Wilson.